Dr. Moody said that palliative care folks are probably the least scary doctors in the hospital. You know, neurologists are scary, orthopedic doctors are scary, but they're not. They're wonderful. I would also say that, and also second that it is wonderful having them. I think every children's hospital should have a palliative care team. I think they are there. It's really not, it doesn't say as much about your child sometimes as much as about the rest of us in medicine, because we're not able to coordinate probably quite as well as somebody like that can. I mean, the neurologist or the orthopedic surgeon or the cardiologist should not be the overall care coordinator for your child. It just doesn't work. And I think when folks like Dr. Moody's around, it works much better. So this is kind of a, hopefully will not be a drinking through a fire hose sort of talk. Please interrupt me if you have questions or if I'm just talking too fast. And I'm going to go over the clinical symptoms of PMD, Pelizaeus-Merzbacher disease, sort of where it fits in the whole PLP1 spectrum. So PLP1 is the gene that's responsible for this. Some of the treatment which people do, and I also have a couple slides about genetics of it as well. And I don't know, Seline's not here, I don't think, today. Oh, good. So she's not going to tell me when I'm wrong. Okay, good. Someone else. Someone else can. Yeah. Okay. Good. All right. I have no one's paying me this. So okay. Indianapolis out the window of a parking garage somewhere. Okay. All right. So Pelizaeus-Merzbacher disease. This is probably an underestimate of frequency, 1 in 300,000, just because it still gets missed. But that's the published frequency. It's an X-linked disorder, so it preferentially affects boys. I have a couple slides later on about the genetics, so I'll explain that more. And it is caused by or associated with mutations or genetic changes in the PLP1 gene on the X chromosome. And it has a spectrum of severity and age of onset. This is kind of the object of our affection here today, the nerve cell. And you see this nerve cell has a cell body, and then it has dendrites, which in classical neurology take in information, and the axon, which spits out information to the next nerve cell down the line. And that's how the nervous system is arranged. And because information has to get down very fast, and because these are kind of long, skinny cellular processes here that kind of are hanging out in the breeze a little bit, they need some protection and need some insulation around them. And so that insulation is provided by the oligodendrocyte, which is a specific type of cell that makes myelin. And this myelin then wraps around, in these nodes here, around the axon. And what that does is it not only sustains the axon, but it also allows electrical conduction down the axon instead of kind of slogging through the cytoplasm of the axon. So the substance of the axon, it kind of skips from node to node to node, and it's much faster. And that lets us transmit electricity in the fastest parts of our neurons, like 15 meters per second, which is pretty fast. If we didn't have that, we would be in single digits per second. So, that didn't come out well. Anyway, so that just shows the oligodendrocyte wrapping around some axons. If you don't have this, a couple of things happen. One is it certainly alters nerve conduction, and the other thing is it probably is not good long-term for your axons. They don't have the same sustaining cells around them, and it causes them problems long-term. This is another slide. This is a little more complicated, but it's not, hopefully not too bad. So again, here's the oligodendrocyte. In it, one oligodendrocyte can wrap around different axons. And this basically shows if you have layers and layers of myelin around something, you can imagine that some stuff there has to kind of be placeholders to kind of everything hold into place. And those placeholders, those things that help the myelin maintain its integrity, one of those is a protein called proteolipid protein. Okay, and so the proteolipid protein is encoded by the gene PLP1. So I'll go back to that a little bit later on after the clinical part. So we take this and we turn this into a brain, and I tell patients in exam rooms, your brain looks like a head of cauliflower, you know, and you can all imagine cauliflower. The outside is the gray matter, so those are the nerve cells. And then the inside is the white matter, which is myelinated, that's why it's white, and those are the axons that connect everything. And then there's some more gray matter, and then there's some ventricles. So this cut is like we cut off the face and we're looking straight at your brain. And this cut is when you kind of cut off the top of somebody's head and looking straight down at them. So these are MRIs. Or this is an MRI. And so these ventricles are supposed to be here, these spaces. And so there's an organization to this. And then here's the cerebellum in the back part of the brain. Here's the brain stem here and here. So the thinking parts of the brain and really kind of where action originates are all up in here. So this is, so we can look at brain best during life with an MRI scan. And MRI is basically a giant magnet you put people in, and what happens is when you put somebody in a magnet, a strong enough magnet, all the protons in the atoms of their cells, they align, and then you give them a energy pulse, a radial pulse, and it gives them energy, and it makes them move around, and then you turn it off, and it relaxes, and when it relaxes, it gives off energy. And as it gives off energy, depending on where it lives in the body and what's around it, the signal looks different to the computer that picks all this up. So what happens is you can change what the computer sees and how it sees it and how much you give, how much pulse you give, and so you can get different sequences. So this would be akin, if this were an MRI, this would be akin to what's called a T1 weighted MRI, where it looks like it would be in life. This is a T2 weighted MRI, and you guys may have heard some of those terms if your doctors have talked to you about MRIs before. And they look like photonegatives of each other, but the important thing for myelin disorders are really T2 MRIs or flare MRIs, and that's because myelinated axons are dark, okay, on T2 weighted MRIs. So the darkest stuff on this image, so even though it's kind of a photonegative of life, this is more valuable to us for myelination disorders. Everything's dark. This is an adult brain, and it's dark. If you're a newborn, you're not very well myelinated yet. Okay, myelination, most of myelination occurs in the first couple years of life, although then it continues till about age 25 to 30. So if you get a newborn MRI, this area is not going to be as dark. Okay, they're going to be lighter. This is just a schematic. This is one of these coronal images, again, looking straight ahead. And it just shows how the pathways, the actual pathways that control your motor system here and the sensory system going up are reflected in here. So the idea, again, that the wiring is all connected. So you can imagine you've got these long nerve tracks. I mean, these are those little skinny axons that have all joined together and are going all the way down. You know, so they're really tenuous little things. Stretching all the way up and down there, but they're long things, and they require myelin to really function well. Okay. So we have mutations in the PLP1 gene, and that affects how you make proteolipid protein, and then you get into trouble clinically because of that. And so Pelizaeus-Merzbacher disease is basically kind of a spectrum within a spectrum, okay? And so classically, PMD really kind of, there's a conatal form, which is the most severe early onset, like you come out of, in the nursery, something's going on. There's the classical form, which is by far and away more common, which is what most children tend to present with PMD. And then there's this transitional form, which is kind of severe, more severe than classical, but not as severe as conatal. And these are kind of a little bit arbitrary. I mean, it's a spectrum. This just talks about how different mutations tend to be associated with different phenotypes or severities or age of onset. And you'll see that duplications tend to be a fairly narrow set, whereas point mutations can be all over the place. Okay, and we'll talk about those. And then null mutations, where you actually lose the gene product entirely, actually tends to be less severe. And we'll talk about why that's the case. Okay, so in other words, here's the PMD spectrum. Okay, and classic form again presents within the first few years of life. Here's the whole PLP1 spectrum. So now we've taken the PMD part of this, okay, and it's actually part of a much bigger spectrum of disorders. And so we have males and some women who present with things out here, okay? We'll go through those a bit. Same gene, sometimes different mutations, but definitely different clinically. So let's talk about classical PMD. So onset generally is in early infancy. The first thing, which most, I know yesterday, overwhelmingly the first sign that people describe, which is the case, tends to be the case, is nystagmus. Nystagmus is jerky eye movements like this, and it tends to be rotary in this, okay, and that kind of talks to just the neuroanatomy that's involved. A lot more commonly, nystagmus, like if you go and take some medicine that makes you dizzy or something like that, is horizontal, so it tends to be just in this plane. Young people with this tend to have a rotary component, so their globes are kind of doing this, and they're doing some horizontal stuff. But it tends to be a very rotary nystagmus early on. As you guys all realize, as the kids get older, the nystagmus tends to dissipate markedly, and then it can come back like if they're tired or they're sick. The nystagmus probably doesn't have a lot of horrible functional consequence. It bespeaks a system that is acting kind of immaturely in a way because it's not yoked up well, and it does settle down. It'd be nice to get inside a baby's brain and know if they're seeing what they see when that happens. But brains are pretty good at compensating for eye movement problems too. The second thing that most people notice, most parents notice, is that children have low muscle tone or hypotonia. And that's different than strength. So I talked with lots of different disorders and families. Hypotonia is what you feel, or tone is what you feel if somebody's relaxed and you kind of move their arms back and forth, how much passive resistance is there. So boys with classic PMD, when you kind of have them, when you passively move their arms, or actively move their arms, but they're not helping, they tend to be loose and very floppy. Or their head control is very floppy. And that's different than strength, okay? Because a lot of the boys are quite strong when they can activate things, but their muscles work, but it's the signal getting down there that's the problem. Feeding difficulties are common early on. Oral pharyngeal function, so how well you suck and swallow and make all that coordinated gets to be is a problem, and so children will have difficulties with aspiration and choking, or just be slow feeders. They classically in neurologic disorders that affect the brain like this, the issue tends to be with a lot of times with thinner liquids rather than solids or pureed sorts of things, and so some families will notice, so they can't handle apple juice, but they can handle thickened feeding or things like that. Stridor, this is kind of a thing we always ask about because this is common, although I think nobody yesterday, maybe one person yesterday had this as an infant.
Want me to make that sound for you?
Sure. I can do it. You can do it in unison. So it's the sound.
You always hear a little of it when our kids laugh and talk.
It's the sound of it's the sound of low muscle tone and your airway kind of collapsing when you breathe in. Okay, because when you breathe in, your lungs expand. There's negative pressure, and it's like drinking through a straw very hard, and it closes the straw. That tends to improve over time because you get some cartilage and stuff in there. Gross motor skills are most affected. Okay, I think if you pick any part of the nervous system that's most affected, that's it. They children with classic PMD do not walk independently. Okay, if they walk independently, they're probably frankly farther along the spectrum, which is fine. You know, if somebody comes back to me and said, well, my child had nystagmus at age 6 months and now he walks, I say, okay, great, he doesn't have classic PMD, he has, you know, SPD2 or something, but that's fine. It's more just functionally what they do, but prognostically, it helps us because we can tell people if you present at this age, at least this is about what you do, and if your child makes us a liar, that's okay. I'm fine with that. I mean, despite that, and I said independently, I mean, we have kids with this, if they have enough truncal control or head control especially, you know, I think a lot of kids get up in standers and they get into kind of modified gait trainers and other things, and that's fine. I mean, whether or not they walk independently, it helps people to be up, you know, more. It gives you independence. It helps with truncal tone. It helps, which can't be anything but a plus for things like scoliosis. You know, it helps your hips develop. It helps all these sorts of things happen that need to happen for you, and you know, it helps your pulmonary function. And so, and even if that's for X number of years, it's better than not having done it. And so, it's not a bad thing to have been able to do those things, even if you don't do them as an adult necessarily. The hypotonia tends to give way to hypertonia, usually in the second year of life, and a lot of you recognize that sometime year and a half, 2 years, that your boys are getting increased tone in their legs, and that starts to become an issue as they get older. Truncal tone tends to remain pretty low. Arm tone also increases, although not as fast as the leg tone happens. Neurologists have a couple different terms for different types of hypertonia. So one type is spasticity, and that's the kind of, if you grab a limb and like kind of jerk it and you get this catch and then it releases. So that involves one set of motor tracts that go down, and then another type is rigidity or even dystonia, where you get posturing or just wherever you can't jerk it. It's like if you try to jerk it, it's like bending a lead pipe. And it's just a different type of increased tone. And the reason those are important is because they can kind of mess up different things at times. Like people with spasticity are going to get very specific sorts of contractures without successful treatment. Very often, people with rigidity or dystonia may not get those same contractures, but the rigidity dystonia may cause other problems with trying to use their limbs, their arms and legs the way they'd like to. And then sometimes they respond to different medicines. And then they also tend to be clumsy, and that's the official term in this case is ataxia. And that says, because all those fibers that need to be myelinated, a big part of the brain that is controls coordination is the cerebellum. And that connects with like the whole spinal cord and frontal lobes, the brain and everything. And so it gets really involved in this disorder. And so kids are very shaky. And they have what's called truncal titubation. So they'll sit there and they'll kind of be like this back and forth because their head control, the cerebellum basically has to take two opposing muscle groups, any two you name, and yoke them together in a way that you make smooth movements. So anything that messes up cerebellar function makes that yoking hard, okay? And you can try it on yourself by like picking up a box that's too heavy for you. If you pick up something light, you just pick it up very smoothly. If you pick up something heavy, you start saying, okay, I got to recruit all my muscle fibers. I'm sending everything I can down to my muscles, and then you start jerking because you can't keep your muscles yoked at their maximum stimulus. And that boys with PMD and other children with cerebellar problems are kind of trying to do that all the time, just with what they're, with their daily activities. Cognitively, these children are alert. They're socially, intact. I don't need to tell you that. They have a lot of problems with language and more specifically with articulation, so speech. And again, the oral pharyngeal function gets in the way. They have what's called pseudobulbar affect and pseudobulbar palsy. So if you do something to interrupt the signal or diminish the signal coming from both sides of your brain and the frontal lobes, what happens is you have a decreased ability to control some things, especially in your head and neck region. And one of those is muscles of facial expression. And so boys with this, and there are lots of other disorders that affect this in the same way, but like if they smile, they make it kind of just stays there sometimes, and it's a very big smile. You'll have kids that you'll have pseudobulbar affect can be something that happens in adults too, where they'll like and usually cry for no reason, laugh for no reason, sort of thing. But I think in children with PMD, it's more kind of an exaggerated laugh and smile thing, and that's relating to once things kind of get going, it's hard for them to kind of turn it off and regroup, and it takes them a while to do it. And that's one thing we see. They have, and I think the spectrum is there. I mean, their cognition, I've not seen a child with PMD whose cognition is not way better than their motor function. Some, especially at the milder in the spectrum, have perfectly typical cognitive abilities. Others have some diminution in that, but it's always better than what you would imagine from their motor function, and that's an important part in advocating for them. Complications, well, feeding difficulties, respiratory problems, and I think Dr. Crossley and Dr. Stevens will be here later, and so they can talk about those. Orthopedic changes, Dr. Moe couldn't make it this year, but the things I think about are scoliosis, hip problems, those are the big ones, and then just contractures in general, in the knees and elbows and hands, although you manage them differently, obviously. PMD spells, which I still call PMD spells after 25 years of doing this. When we first encountered these, we said, oh, these are seizures. And they're not epileptic seizures, I don't think. I mean, we've stuck needles in people and done other things, like panic compressed, looking and stuff, and not found discharges. Children with PMD can have seizures, okay? I mean, anything you do to the myelin like this will change the way the gray matter works some, and it's there, but that's not most of what these are. What we think these probably are some sort of autonomic dysregulation or problem with how the autonomic nervous system regulates itself. The autonomic nervous system is that part of the nervous system that controls all the kind of day-to-day functions in your body. I have a slide for that.
Dr. Walsh, what do you use for those spells?
Various things. So, in our very small group of, in a few, 3, 4, I don't know, we found Tegretol was helpful, carbamazepine, which also means oxcarbazepine may be helpful, which is the kind of newer, less kind of toxic version of carbamazepine. We've gotten a lot more aggressive about treating autonomic problems and other disorders, cerebral palsy and things like that. And there are a lot of medicines now that we use in those. And I think I counseled somebody yesterday that they were already on one medicine, and I said push that to its conclusion or whatever. But if it doesn't work, then I would try either carbamazepine or oxcarbazepine. But if those don't work, I'm itching actually to try some of the things we now try in dysautonomias, because I think that those could also have value. So it's gotten more complicated. I know that's not quite the answer, kind of.
We know you're looking, so that's important.
And then I think a complication is variable lifespan. As Dr. Moody said, conatal form, even the conatal form, we expect that we can get kids into teenage, and maybe a bit older. After that, we don't know. I think 70s is hard because I think most disorders that cause this degree of motor deficit probably do reduce lifespan some, but it's more because of things like accidents or respiratory problems or things. This disorder does change over time, but a lot of it is the complication, the other complication stuff. And if we can treat those, we can have people live a good long life. Yeah, so, question subcortical seizures, question autonomic instability. So just, this is the differences. So this is a brain with EEG lead locations overlaid on it. So when we look at an EEG, we put wires on the scalp and electrodes on the scalp, and we expect the brain to talk to us from these spots. So there's a lot of brain underneath that cortex, and the brain has a lot of current, but not that much. I mean, you measure it in microvolts by the time you get to the scalp. So 1/1000th of or 1/1,000,000th of a volt, 1,000. And so I think that it's sometimes we do think that sometimes things can arise deep, but we've looked at that, and it's hard to do that. It's hard to find anything that looks like a seizure. This is the autonomic nervous system, and basically it kind of starts up here in the hypothalamus, and then there's different, there's clusters of things that run up and down the spinal cord, but you see these are all the things it controls. It controls breathing, it controls how your blood vessels constrict and dilate, it controls blood pressure, it controls how your heart pumps, it controls how your gut moves, your endocrine system, so all the hormonal stuff is involved in it. So there's sweating, drooling, temperature regulation. So it's really the kind of underlying system for your body. And these spells and if you haven't experienced these, the kids tend to become somewhat less aware. But we've also seen that same thing in kids without PMD. With it, their blood pressure changes, their heart rate changes, they may get stiff, their GI tract does odd things, they have color changes with it, their temperature may go up or down, and it looks like an autonomic failure at that point. And so the medicines that we use, even whether they're seizure medicines, whether they're blood pressure medicines, whether they're Valium relatives, they're basically there to modify some arm of either the autonomic nervous system or something that's causing it to act up. And that's how we treat it. See, Patty, there, ahead of the slide, part of this. So how do you make a diagnosis? Well, you've got to think about it. And the reason you have to think about it is probably in my experience, about a full third of the MRIs that are done initially are read as normal, even though they aren't. Because again, infant MRIs don't have a lot of myelin in them, and unless the neuroradiologist is keyed into what he or she is looking for, they may just think, oh, it's within the range of normal myelination for an infant. So you need the clinical suspicion. So I think the big thing is this nystagmus, if it's there, and it's typical in a boy who's got low muscle tone. It's a central nerve. It's usually either a vision problem or a central nervous system problem, and this should be high in the differential diagnosis for that. So this is a normal T2 weighted MRI. I showed this earlier. Okay, so white matter. Remember, this is like a photonegative. So gray matter is actually light gray. White matter, because it's myelinated in this sequence, is dark. Okay, and then spinal fluid actually is bright. This is a young man with PMD. So you could, we've actually seen adult MRIs in children with PMD, or adults with, or children with MRIs read as normal. Because you look at this and you say, yeah, it looks great. All the parts are there, the volume's right, except that this is all bright and it should be all dark. And there's a little myelin there, there's a little myelin there, there's some myelin in the nuclei here, there's a little bit there, but there's a lot of, and there's some myelin here in the cortex, but there's a lot of myelin missing. See, there's some in the corpus callosum, how it's kind of shaded dark. But it's mostly missing, and so this is what happens in classic PMD. This is a normal 37-week gestational newborn. Okay, so this child's born 3 weeks early, so not really prematurely, a little bit. And you compare it to this, and there's more myelin here than there is here, frankly. But you get the point. Is that if this is normal, if this is the way the pattern we're looking at a child with PMD, it's hard to pick out that difference unless you're thinking about it. and that's why I think that's why it gets missed. Now there are some differences. There's a little more demyelination or absence of myelin up here or out here near the cortex and so on in this child because they haven't developed yet, but still. So conatals, so that's the classic form. Conatal version, basically symptoms at birth more severe, more expectation of less developmental attainment and prognosis overall. And then if you go to the other end, so once you get past classic, you start getting into classic PMD, you start getting into the spastic paraplegia type 2 spectrum, which these children walk. That's the single biggest distinction. Past that, seen even within the same sibling pair, even within the same family, children who clearly everybody would put in, even as a very young child, a boy who clearly people would put into SPG2, and his sibling who, had you seen the child at 6 months or 10 months, you would have said, oh, this looks like pretty much classic PMD, except that his tone was better, and that was actually the thing, his tone was better, and then he goes on to walk and do things. So point is that there's not, I don't know that there's, other than the walking, I don't know if there's this hard, bright line that separates, and you've got to realize that this really is a spectrum sort of disorder. They have dysarthria. They have dysarthria. They get spasticity early in life. They tend to be ataxic throughout life. We think about all these disorders as something where you improve gradually over childhood. You are stable do a little better over childhood. You tend to plateau in teenage and early adulthood, and then as you get later, and then some children will overlap that with later teenage, early adulthood, mid-adulthood, start having some more and more problems. You just shift all that to the right if you have a less severe version of this. So dysarthria is problems pronunciating. Now you're going to do it. Pronunciating, yeah. That's the spelling. In this case, no, it's just they have trouble pronouncing words. Okay, and it tends to be up here, and you get a combination of just not clear articulation, but then what's called prosody, which means that how your voice regulates when you talk tends to be off as well. It may be a little sing-songy. It may be, the words may be very drawn out. And then children may have will have bowel and bladder problems with this. They may become completely continent and only to lose it later on in teenage or adulthood, depending on the age. And that's because the spinal cord is involved with this, and the brain's not. Their brain symptoms are not as severe, but their spinal cord symptoms are more evident. So this has become a kind of a hot button topic, I think, for a lot of families, because the way this was originally described, and it's still true, is this is a dysmyelinating disorder. This is not a classic leukodystrophy where you're doing okay, you start having symptoms, and then you have a relentlessly progressive downhill course, like with the Neurology or probably the metasomatic leukodystrophy or something like that. This is problems making myelin to begin with, and so the original dogma was, well, this shouldn't be progressive. This should be something that, okay, they don't have this, but the nervous system shouldn't change from then on, but it does to some degree. But other things change too. And so the things that change, you do get progressively spastic or rigid with this over time. I mean, kids get stiffer. And we'll talk about that in a second. But then there's also some other complications. So if your hips go out, if you have bad scoliosis, if you have contractions, those are complications. And even if your nervous system's doing okay, that still can be limiting. So that's bad, but it's also an opportunity to treat something and to minimize that as much as you can so that boys do better. Respiratory, GI, infectious complications, And then the question about accumulated CNS damage, which really isn't, the slide shouldn't be there. Accumulated CNS damage, and the thing is about, it depends on the mutation and everything, but to some degree, but the overarching thought about this point is that if you make abnormal PLP protein, or pluripotent protein, the oligodendrocytes don't like that very well, okay, the cells that make it. It gums up their works. It's proteins made in something called endoplasmic reticulum, and then it gets kind of put together in Golgi apparatus and then stuck out in the cells.
Is there a way to prevent the progression of spasticity? Because my son, he walks with the walker, with his gait trainer a lot for 1-2 hours on his own. And I was wondering if he keeps doing that, if we could kind of prevent this spasticity.
So it helps to do that in range of motion and things. It will not completely prevent it. And I think I have a slide that I talk about some medicines and things here and different ways to do this. If not, I'll just talk about it when I get to the treatment part. But yes, but keeping people mobile and stuff helps spasticity. So the tone's there. The tendency is going to want to be to get tight hamstrings and things. So can you keep beating that back so that you keep range of motion? You know, the spasticity is going to come. You know, and then can you lower the spasticity with medicine or do other things? And the answer is yes, to a point, and we'll talk about that. So the thing is about if you have this abnormal protein product being kind of gumming up the factories of your cells to make protein, then the cells don't do well and they can actually die. And if you do that over time, then that does represent damage to the central nervous system. And so it's not a far throw to think that children with this would change over time because of that, although it seems to be a very slow process. The other thing, you know, the other corollary to that is that we know that children who just have a PLP1 null mutation, where you just delete the entire gene so there's no product being made, actually look better. So it's almost better not to make the PLP1 protein than it is to make too much abnormal PLP1 protein. Or PLP. This is also just for perspective. Families with PMD shouldn't feel alone, like we're out here is the only disorder that has this. This is actually currently, so these are all the hypomyelinating leukodystrophies, okay? So they're not classic, these aren't the classic leukodystrophies. These are children who are born with, you know, limited degree of myelin production. And PMD is, at this point, usually overrepresented in any series where people have gone through and found genetic changes in children with MRIs that look like this. But it's probably not 50, it's not anywhere near 50% of them, but it's definitely the largest group at this point. And so there are a whole bunch of these, and there are going to be some more. And so it's this slide is more there for families. Sometimes in the past years, I think everybody that we've seen in the past few years has had a child has had PMD, but we've had in past years families that come in and the child did not look like a child with PMD. They had something else. And this gets more to those families. They probably have one of these things. So it's realized that there's not everything that doesn't make myelin as a newborn turns out to be PMD. So the genetics, our bodies are made of cells. So I just did this like this rather than try to do a drawing and see how it goes. So our bodies are made of cells. Cells have nuclei in them. So the nucleus of the cell is where the chromosomes are. And the chromosomes are made of DNA and protein. DNA is basically our genetic alphabet. You know, if you have a gene, you have a series of 4 letters strung together in a sequence that means something to the reading apparatus. And then genes are basically specific segments of that DNA with a very specific alphabet. Okay, the genetic code for a gene it tends to not vary from person to person much, or it shouldn't. Any change in either the copy number, so if you have too many copies of that gene or too few copies of that gene, so it's been deleted, or if you change the reading of the gene so now it reads to make something else, or it makes a change that makes the gene turn off protein production, cause a change in function of that product, that gene product. So you may not make any gene product, you may make too much abnormal gene product, you may make the right amount of product but it doesn't work right once it gets out into the cell, and that's really the basis of how genetic disorders happen. The PLP1 gene is on the X chromosome. So we all have 23 pairs of chromosomes. We get half from our mom, half from our dad. The 23rd pair are the sex chromosomes, and so boys have an X and a Y. So males have an X and a Y, girls have two X's, females have two X's. So if you only have one X chromosome, it means that any gene that is on the X chromosome is there, in theory, only in one copy. Whereas if you're a female, you have two copies of those genes. The Y chromosome, we won't talk about the Y chromosome, it's got a few, but it's not important for this. So basically a male who has a PLP1 gene mutation on his 1X chromosome will generally have some version of PMD or spastic paraparesis. A mutation in a female's PLP1 on one of her X's is usually kind of counterbalanced by a normal PLP1 gene or unmutated one on the other X chromosome. And so that's good for women, because then that means that generally women are going to be either not affected or less affected. And you say, well, why is it variable? Well, women, even though they have two X chromosomes, in each cell, they only have one X chromosome functioning. They turn off one in every cell. So you can imagine if you turn off, if you have half your cells, say you turn off half of the normal chromosomes, the chromosomes without the mutation, and then you turn, and then in the other 50% of cells, you turn off the mutated ones, you're going to have, it'll be balanced out, you'll probably be okay. To say you just randomly turn off 90% of the chromosomes that don't carry the mutation, so now you've got 90% of your cells with the mutation expressing chromosome turned on, then you're going to be affected. You're probably going to be affected, and you may be affected very similarly to the way a boy will. The other thing is it changes over time, and so we've seen young girls who have been affected, who look like they have some features of boys with PMD, but then they get better. We have some that have basically PMD. We have girls unaffected, but then when they grow into women later on in life, they may have some symptoms as carriers. And they're not going to be as severe generally as the boys with the same mutation in the family, but they can still have a variable degree of symptoms. And so it's important to realize that, I think. Does that make sense? Okay. Nobody looks dazed, so sleep maybe. Okay. All right. So treatment. Supportive care, so nutrition and pulmonary treatments are needed. And the nutritional thing is, I think that the early years, I almost never saw I saw almost no one with the G-tube in this population of boys. As we've gotten farther along, I think some boys have had them, and I think it really depends how the child's doing nutritionally. It's good to feed your brain, so it's okay. It just depends what the boy needs. They may not need it their whole life. They may need it early. They may need it much later in life, as an adult, and not early. It just varies, and you just have to take each case. The thing is you want to not be getting pneumonias, and you want to be growing and thriving, and those are the things. And you don't want to be taking 4 hours for each feeding. That's because nothing else happens then at that point. You don't learn and do other things. So those are the things that we like to look at. Rehab therapy, so OT, PT, speech. Most states, I think, have some 0 to 3 program for therapies. After that, a lot of times it's pushing advocacy to get therapy is done as you get the school system. For those of you who asked yesterday, the letters are written. We just have to get contact information and get them sent. Spasticity management and then orthopedic management. So spasticity management starts with therapy, embracing things like AFOs, ankle foot orthoses, other sorts of orthotics. And if that's not enough, which usually it's not going to be by itself in most of these guys, we look at oral agents, kind of going from increasing from least invasive to most invasive. We look at oral agents, so diazepam or Valium is something that's used a lot of times in younger children. Baclofen, dantrolene, tizanidine, sometimes dopamine agonists are the medicines used for Parkinson's disease actually because of the rigidity. These all work at different places in the nervous system. They all have somewhat different side effects. Their unifying characteristic though is they work everywhere. And so if you have a child who has a lot of spasticity or rigidity in his legs but is hypotonic and has poor head control, and you give them these, you're going to reduce tone everywhere, which means if he has kind of marginal head control, you may lose that head control, and so you have to be cognizant of that. It doesn't mean you don't try them, it just means you've got to have your eyes open going into it and saying, okay, this can happen, let's watch for it, and if it does, we've got to back off and do something else. There's no perfect treatment for this stuff, so we have to use what we have. Botulinum toxin injections have been helpful because they're more localized. They kind of mostly stay where you put them. There's a little bit of systemic effect, and you do have to be careful to make sure that you're not causing problems with respiratory drive, secretion, secretion management, clearing airways, things like that. Because sometimes when you inject in the legs, if you give enough, you will get a little systemic absorption. And if a child's really tenuous with their swallowing and things, you can make that worse. And botulinum toxin starts working about 48 hours after you give it. Its maximal effect's about 2 to 3 weeks, and it lasts 3 to 6 months. And so we do keep an eye on kids for the first few weeks, especially to make sure that they're going to do okay with it. And we tend to start with low doses and then work the dose up to some degree in subsequent injections. You can give it about every 3 months at the minimum. You can't give it much closer than that. You build immunity to it more quickly is the theory. But the thing is, it does work in a pretty localized fashion. So if you have adductor and hamstring tightness, and or you have wrist tightness, and you want to treat that and only that, it can be very helpful. It is shots. I mean, they're intramuscular shots, and they hurt. So it depends on sometimes we'll do it without sedation. Sometimes we'll have sedation ability to do it and things. So it varies. But sedation in and of itself is the procedure. Surgical procedures, I probably should reorder these. So I'll start with the bottom. So SDR, selective dorsal rhizotomy, you selectively cut nerve roots back here, which then kind of interrupt some of the feedback loops, which allow relaxation. This is not something that's done at Riley, but like WashU, Washington University, St. Louis Children's, they're big proponents of it. So a lot of times it just depends on your home institution. In this, I don't know, it's been classically looked at in people with spinal cord injury and things probably more often, and to a lesser extent cerebral palsy. There's not a literature for it in PMD necessarily. Intrathecal baclofen pump, so that's where we put a catheter into the spinal canal, and it runs under the skin, and it comes around. There's a little pump here that then what happens, there's a little reservoir with baclofen. And the idea is that you can, where you place that catheter in the spinal cord, it will preferentially affect the spinal cord at that level and lower more than it will affect it higher, okay, to some extent higher. But the point is that you're not making the child sleepy with it, you're not affecting the head and neck muscles as much with it, and so you can kind of almost line it up to the gradient of spasticity that you see in these boys. And then the reservoir is in there under the skin, and so what they can do is they can reload and they can program and stuff to pump from the outside, and then reloading is just an injection rather than a surgery. So we generally quote people about it just in general with baclofen pump for children with spasticity in general, about an 80% success rate, assuming they do like a pre-test. Initially you do you put the catheter in, you do a lumbar puncture, and you inject baclofen just as a test dose to see if it actually helps the person. So if it does, there's about an 80% success rate in doing it. There's about a 20% failure rate, give or take, 5-10% either side. The way it fails is it breaks, infection, they just don't tolerate it, something else, skin breakdown, something else happens that has to be removed. So it's one of those things that when it works really well, and when it doesn't, it's just a mess for months because you're trying to deal with trying to make it better and everything. But having said that, we recommended it and used it successfully in a lot of people. You can see again where, getting back to Dr. Moody, when you have all these sorts of things, it's a lot to talk about and a lot to think about, and having somebody help navigate this, in addition to neurology and orthopedics and everything, because we all have our own little favorite ideas about what works and what doesn't work and so on. And yes, we all like to pride ourselves on being listeners, but I think it's good to have somebody who's stepping back and taking the big picture and saying, gosh, this person's now on like 3 spasticity medicines and a baclofen pump, and they're getting ready to do a tendon transfer, and so it's good. Okay, and then just local, can you make tendons longer, can you cut tendons, can you rearrange muscles, things like that. Again, more invasive surgery. And then scoliosis surgery obviously is the specter of that is there for a lot of people. They start with usually things like braces, soft braces, hard braces, things like that to try to prevent progression. But if it hits a point where it's impacting the respiratory system or causing horrible pain or those things, then surgery becomes more important. Can we make this disease better, disorder better? So things have been tried, and someday I hope to get up here or get it. I think I always tell people that the doctors will probably be the last to know when the definitive treatment comes out, because it's been that way for gene testing, for support groups and everything else. I still remember when Rett syndrome, the gene came out, sitting in genetics preclinic talking to a bunch of other geneticists, and somebody walked in and said, yeah, we just got an email from the IRSA, the International Rett Syndrome Parent Support Group, that they found the gene in Texas. And so that's the good part. So, but having said that, basically, this is what I talked about earlier. Normal PLP1 gets kind of made in the ER and the Golgi and gets up to the membrane eventually, or gets here and eventually becomes part of this membrane structure in the myelin. If you misfold it, it causes problems here, and it causes the cell to basically go bad. If you overdose it, it happens at a different spot, but the same result is there, as the oligodendrocyte basically becomes poisoned by it. So it's the best way I can think to put about it. So if you can stop this from happening, so one thing to do is you'd like to be able to get back to here and make a normal product. Well, that's really hard to do in gene therapy. It can be done, but it's hard to make it actually work in all your cells. The other is, can you stop this part, so maybe you don't make this, but at least you don't get this. So active trials, and I think there was one other one, which I should put up there, but there was one, and this is through, I think this was Duke and another institution. But basically, looking at neural stem cells, because everybody wants to know about stem cells, they've been able to do these things, generate functional myelin, prolong mouse survival. They've been able to, by basically knocking down the gene, been able to improve myelin formation. They've been able to skip, or basically, like if there's a mutation in one little segment of the gene, can you like bridge over that so that then the reading frame then works again, okay, so that the gene then is transcribed into a somewhat more functional protein. Can you do something to kind of drive the metabolic side of this, to change the gene, either gene expression or to make it more likely to make a normal product or a functional product through just biochemical means like with cholesterol, hormonal treatments, and then they're actually looking, these are our cell growth pathways here. Oops. These are cell growth pathways that they started trying to use to look at how to make oligodendrocytes make myelin better. I'm going to skip these because no one can read them from anywhere. But basically, the idea is that mice in which they've done these manipulations to have done better than mice that they haven't. This is the big one. So, so they did cord blood transplant, and so basically they had 2 boys with PMD and both with cord blood transplantation. They had deficits, as noted, and fairly typical, although there was some disparity between 2 boys. They went ahead and went through their standard procedure, and then they followed them. And they noticed that they had neurocognitive improvements, no evidence of decline, showing stable or improved myelination. And as they said, it's encouraging, but they need longer-term follow-up and more data. And they talked about how actually this sort of a transplant has a good survival rate when used in other disorders, and so it's something that can be done relatively safely. And this just talks about some of the development. So this is in months, so visual receptive abilities at 8 months, so no, it's been about 7 months, at 82 months, we're about 46 months. And it sees progressing almost significant delays. Motor scale, fine motor, 6 months as an infant, so a couple months behind. Here, about, significantly behind, had gotten to about a toddler, early toddler level. Gross motor skills were behind. Patient 2 had a little bit better, or a little more preserved function, although, again, progressed with age, but still had delays. And I think the problem is if you have an N of 2 or an N of 4 or something like that, you have to compare it also to what boys without this do, especially, unless they're at the severest end, boys do progress and function. They do gain skills early on, and so you have to line that up and statistically prove, yeah, this is a lot, this is better than if we didn't do it, and that's still where it's a little bit hard. These slides talk about basically as they went on in their therapy that they got some more myelin compared to earlier on, which was encouraging. This is actually 3 consecutive MRIs from the same patient, a patient who was not treated, though, and you see that you can start seeing this overall general shading, like here in the internal capsule and a little bit out here and stuff, where myelin actually is getting laid down even in a boy who's not treated with stem cells with PMD. And so the point is, again, I really want this to work, and I mean, this is the way to fix this stuff, but we just need good data to know for sure that it's going to do it, because it's a big deal to have a transplant. It has a mortality and a morbidity with it, and it's important. So I think that they're working on it. I think they're on the right track, and I'd like to see this work. We just need data to really know. Okay, questions?
So Dr. Walsh, you are saying that PMD child that does not have transplant will probably produce some myelin as they mature anyway?
I think, unless, I think the children at the severe end of classical or conatal, I think their MRIs, I think, look about the same from ages 1 through 20. I think they don't, if you look really hard, I think everybody else, you see a little bit of difference, and don't get hung up, please, on the MRI picture, because I tell people, I don't want to see another MRI after the first one, basically, if we have the diagnosis, unless something dramatic happens, that we didn't expect, because it doesn't matter what that MRI looks at that point. It's more important from a clinical reason for that child, or a clinical purpose for that child. I think it's more important what the child's doing, and we should be putting our resources into making that child as functional as he can be and doing what he wants to do, rather than running through MRI scanners just to see if there's a little more mild or not. So he'll tell us more than the pictures will. From a research standpoint, it'd be great, but that's.
I read a little bit about a study done with transvascular autonomic modulation, but it was done more with people with multiple sclerosis. Has there been anything regarding transvascular autonomic modulation with kids? Maybe not with PMD, but anyone with CP or any other neuromuscular? No.
But they will. So. Grace, do you know, or is it vascular?
You have to share your
It's so it's a different disorder, so I don't know, especially with the CP, because that's MS is structured a lot different disorder. Other questions? Thank you.